Thank you for the invitation, Dr. Sangwan, Ken, and Neil here. So I'm going to speak to you from a clinician's perspective. So typically, what is it that we are looking at? What are the phenotypes like? Some of these diseases that are associated with syndromes. What is the role of genetics and challenges in the management? So this, I would say, is a landmark paper that we published from India. 1,743 eyes of 1,155 children of new childhood glaucoma cases in a year. This is what, like what Ken was saying, would take a few years in the rest of the world put together to get. So we have a huge volume of patients, and we actually need help to be able to treat them, identify the conditions, and treat them better. So of this, close to 20% have ocular anomalies, and this is an underestimation. Close to about 4% have syndromic associations. Remember that syndromic associations is an ongoing process, right? As a baby, they may not even have a manifestation, and as they grow older, you will be able to pick them up maybe when they are in their teenagers or even older. So this could grossly be an underestimation as well. So when you look at pediatric glaucomas, there are phenotypic similarities and there are huge challenges with diagnosis. All these are congenital glaucoma, enlarged corneal diameters, elevated intraocular pressures. Some of them you may see a HAPS trias, some of them have some kind of a keratopathy. Ultimately, we treat them with a similar kind of surgical intervention. Some clear very well. One surgery is enough to make things better for the child. Some of them don't clear. Pressures may come down, but the cornea never clears. May need a keratoplasty. Some of them may clear with a keratopathy in the middle. Some of them you may be able to pick up a diagnosis only after you treat and the cornea clears. And this was this mother who also had actually a familial aniridia. And this is the cornea after it cleared. If you see a peripheral prominent Schwab's line, and then you go back and see there's some kind of change, like a bite spot like picture that you see. And now you know that these eyes are phenotypically, to begin with, maybe similar. As they progress and as you treat them, they may end up having a different kind of a picture with time. All of them have different kind of genetic mutations. But if I just showed you that first picture, panel, with all hazy corneas, they're all not primary congenital glaucoma. Remember that they can have similarities, but only with time we will understand. Now, as a clinician who was not into genetics, we never had the opportunity a few years ago. I would say that yes, this eye clears well, and this eye unlikely to clear, may need more surgeries. As a clinician, I've learned to understand that. But now you can actually put that genetics together and say, when you see these eyes, now you can actually tell that this is this type of a mutation, and this is likely to require more number of surgeries that can only be proved with a genetic testing. Syndromic and systemic associations, like I said, one of the commonest syndromes that we see is Sturge-Weber's, and this is not difficult for us to diagnose, right? It is an encephalo-trigeminal angiomatosis, and usually it is unilateral occurrence, and ocular involvement is quite significant. There is its sister or brother, you may call, is a condition called phacomatosis pigmentovascularis, where you have Sturge-Weber's like picture with also the pigmentary nevi that are present. And you see that this is the kind of appearance. You have a bilateral presentation often, you have pigmentation, and this is a multi-system condition where it's not just the encephalo-trigeminal involvement, but you can have the rest of the body being involved, the trunk as well as the limbs. Why is it important to distinguish these two conditions? It's important, very important, because we know that this is a bilateral disease. At least Sturge-Weber's, though it is difficult to treat, you have the other normal eye. And this condition, you have bilateral involvement. They have significant more systemic involvement. Recently, we published this article where they have significant anemia because of the extent of hemangioma that they have. In fact, we have children with 4 or 5 hemoglobin levels who may require multiple interventions before you even go and touch the child. Systemically, they need to be stabilized. We have children who have multiple episodes of hemiparesis. So, the child doesn't come for the next 4 months, and then I ask the mother, what happened? Why were you delayed? No, he was admitted in the hospital. He had an attack of hemiparesis. That is at the age of 3 and 4 years. So they have significant higher episodes of hemiparesis, and surgically these two diseases behave very differently. Sturge-Weber's, they do much better compared to phacomatosis, and also the number of complications that they have post-operatively are also higher. So this is again unilateral congenital glaucoma. We know that 80% of primary congenital glaucomas are bilateral. You may have a unilateral presentation, but when you have a presentation like this, always think that is something beyond just the PCG. So you can see that little bit of thickening on the lid and little bit of pigmentation you see on the temporal side. Examine the face as a whole. Typically, they have pigmentation on one half of the face. This is NFN-related neurofibromatosis. It's important because they can have systemic involvement, systemic malignancies. And also remember that this disease can progress relentlessly and we may lose the eye as well. But what is also very important is recognizing the condition and diagnosing it is important, because for more of these monogenic disorders, it's possible that there could be some treatment option available. And this is a very exciting thing that we found, that selumetinib is a drug that is possibly used in very severe type of plexiform neurofibroma which are inoperable, possibly try to decrease the proliferation of the tissue, and this can also be used in congenital glaucoma. So this was a premature child that was referred, a premature baby with congenital glaucoma, came all the way from Mumbai, had the surgery done, cornea cleared very well. We were very happy. We thought it was a premature child along with glaucoma, that it's taking time for the child to recover. By about 6 months, the child would not have an eye contact despite his disc not being very bad. And with time, the disc cupping kept progressing despite the pressures being under control. And then later we came to know that this child was in fact asked for a neuroimaging and had a genetic testing done. Born to non-consanguineous parents, homozygous TREX1 mutation, which coded for Aicardi-Guteroid syndrome. And this is a very, very difficult disease to treat. And now what next? So what is important? In fact, I learned this from these parents, that they went through an IVF. Parents chose to undergo pre-implantation genetic testing and screening and had an implantation of an embryo that was normal, and these parents have a normal child now. So it's very important not just to diagnose, to be able to help the child with the diagnosis, but also help the parents with their future generations as well. So this is again a very interesting and a very a topic that I like a lot, about ectopia lentis. All ectopia lentis, whether you like it or not, are associated with some systemic problems. So if you have a 12-year-old who comes with high myopia, ectopia lentis, all of them are not morphins. They can have several other conditions that are associated. So we need to remember that sometimes clinically we may be able to recognize it, but most often we may not be able to. And remember that some diseases can have serious ocular as well as systemic problems. So it's very important to be able to pick up all these changes, to be able to diagnose the conditions appropriately. Marfan's, Weil-Marchesani, homocystinemia, this is again not very common, but yes, only if we look for them, we will be able to identify. Just fasting and waiting for a GA, you may lose the child for a deep vein thrombosis. So we should be very, very careful in what we diagnose. Other condition with ectopia lentis, referred for a congenital glaucoma. Don't do glaucoma surgery in them, you lose the eye. It is an LTBP2 mutation with a subluxation or a dislocation of the lens. All they need is a lensectomy. Trabolsis syndrome, this is again something that we don't understand much about, but we know that these eyes progressively, the sclera thins and they develop spontaneous blebs, hypotonia, and you lose the eye. And if you are not careful, just with your surgical intervention, you may be worsening the condition. So what is important is systemic evaluation is very, very important. And we, like I said, we are a learning. With time, we will be able to pick up those conditions better. But if there is any situation where you're treating it with your best ability, but if it is not responding to treatment, or there are features which are slightly different, ask a question, go back, re-look at it, deep phenotype, or maybe get help of the genetic investigations to be able to identify the condition better. Then we should be able to help them with their systemic evaluation and, like I said, help the family with the child as well as with the future generations. So to summarize, it's very important to recognize the conditions and to be able to take help of genetic testing and parental and sibling screening as well, to be able to diagnose, appropriately treat, as well as follow them up. Thank you so much, and all of you are welcome for the IPGS 2025 in December 12th and 13th at Madurai.
Thank you so much for a wonderful talk. I think we have time for a question. Any questions?
Can I make a comment?
Yes, of course.
So, thank you, Dr. Sirisha. This was really an eye-opener for me. No, this is just a comment on the pre-implantation genetic diagnosis. So, I'm a retina specialist. And so this is now quite commonly done across the country in, many, at least in all tier 1 cities. Especially when the parents both are carrying a mutation, or they have one child and they're worried about the second child carrying the same mutation. So an IVF is done, and then so a laser guided biopsy at an 8-cell stage it's a trophoblast stage. So at that stage, a laser-guided biopsy is done, and a mutation analysis is done of those. So then they decide, which embryos, can be put in. So I have at least a few patients, parents who've undergone this and, have a successful child with no mutation.
Yeah.
So,
It is amazing. And for me, this was the first patient that I came to know about. And then, so what is very disheartening is that when one child, at least in our part of the country, there's one child with congenital glaucoma blind, and then the mother doesn't show up for the next 2 years. And then they come with 3 children, all 3 of them affected with the same condition. And unfortunately, all of them in the lower socioeconomic strata. So one is we need to, first of all, treat this child, and we should be able to tell, because they think that, this child is blind, we need to have one more baby so that they can take care of the other child. And not realizing that the same problem is happening in the next generations as well. But this was an eye-opener to me, and now I tell this. I take time to tell the parents that if you are planning the next child, you're telling us, and we will be able to help you.